So I'm often asked, what are the key symptoms or red flags that medical providers should look for to make them think about CGD? And I sort of have a general list that I provide, and so I'll start in no particular order, but I think pneumonias are an important one. So any pneumonia in a child or a young adult that resists long-term treatment, where you begin to suspect that maybe there's something more here than just that the patient, oddly got an infection. That's a patient where among other immune deficiencies, CGD should be looked for and tested for. If you have a pneumonia in which Aspergillus or other mold fungus appears, almost certainly you should look for CGD. And then there are odd bacteria that rarely infect other people, but happen a lot in CGD patients. One of them is a kind of bacteria called Burkholderia. Burkholderia cepacia, curiously enough, mostly affects plants, but it also means if you got rotting plants and soil and things like that a patient gets exposed to, they can get a Burkholderia cepacia infection. So if you have a pneumonia and a bronchoscopy is done and Burkholderia comes out, boy, there aren't too many things that you've got. Maybe cystic fibrosis is one of the other ones where Burkholderia is a problem, but CGD should be high on that list of diseases that you look for. Nocardia is another one. Now, the problem is that CGD patients also get things that commonly infect other people. So somebody gets a Klebsiella pneumonia, or that can happen just because you just got bad luck and get a pneumonia. But that may be another organism where it might be worth, particularly if it's in a young child. Interestingly, pneumococcal pneumonias do not affect CGD patients. So if a child or young adult gets a pneumococcal pneumonia or a Haemophilus influenzae pneumonia, CGD isn't on the list. I only say these negatives because those organisms that are targets of CGD patients in particular are real red flags. Right? And I use the word red flag in a strong way because it just isn't that difficult to go get a CGD test. And if you have a patient infected with one of these, please get a CGD test. So what about other things? Any liver abscess in a child or young adult that doesn't have a clear exposure that would explain all that's going on, such as travel to an endemic area where you might, get an amoebic abscess of the liver or something. But, here in the US and across Western Europe and Japan and so on, if a child or young adult shows up with a liver abscess, better test for CGD. Recurrent lymph node abscesses, of course, are a bit of a plus minus. Some people can get lymph node infections, but if you have a patient who just gets, lymph node infection after lymph node infection, and particularly if you don't get an organism or you get a bacteria that's could be specific for CGD, need to test for CGD. And one of the key things is an unexplained bone infection in a young child without traumatic injury. So of course, bone infections in children can occur from, an open break or a car accident or something like that. But if it happens spontaneously, then CGD should be tested for. There just aren't that many children who get an osteomyelitis. And so CGD should be on the list. And if it has a CGD-like organism, for example, I've seen many children with CGD present in infancy or very young childhood who get an osteomyelitis that is a bone infection with Serratia marcescens. Very unusual organism, but happens a lot in CGD patients. In fact, if a young child gets a Serratia soft tissue infection, Serratia isn't a very common organism to cause infections. It's not like staph, which probably almost all of us may get a staph infection, every couple of years somewhere. But but and so that isn't the kind staph infection isn't the kind of thing that we would say, okay, we need to think about CGD, because yes, CGD patients can get staph infections, but so can other people.